So we talked about endoleaks, peripheral hemorrhage. Any other use cases that you guys have liked and are thinking about using it more or introducing into different parts of your practice?
Yeah, I mean, certainly peripheral hemorrhage is the proven indication for this, right? This is on label. It's got a lot of data behind it. I think it's a very justified approach to that problem. When we start veering that off, just realize now it's just, does it make intuitive sense to you, and is there some data that supports its use? We've really liked the way it behaves in portal varices. So I think as an adjunct to a TIPS procedure, let's say, where you just feel like there's a persistent varix and you want to fill it up, we've had a lot of nice success using lava to fill that space. It's very opaque. It's very easy. I'm not worried about the catheter getting stuck, and I know exactly when to stop, so it's not then rushing through the tips I just created. So I've been very happy with that. Endoleaks is another off-label indication where I think there's a lot of utility for liquids. I think we can all appreciate that in many of those cases, there's a space to fill in the native aneurysm sac, and there are vessels that are providing both inflow and outflow to that endoleak. And it's difficult. It always looks like it should be easier, but it's difficult to navigate these catheters into either all or some of those vessels. I love that liquids can get there for me. So when I see that I'm in the area of the sac where contrast is accumulating and I inject a liquid, usually the less viscous liquid, it will make its way through the sac into the outflow vessel. And I will feel like I've really done a complete job for that patient. So I think endoleaks are a great place for this. And there is some data supporting that when it comes to Onyx at least, but it's going to take a little time for some of the newer products to receive that kind of literature-based support. And I do think that some of the venous applications that we're used to using, maybe it's a varicocele or pelvic venous disease in women, where I think there is at least opportunity to explore the role that a liquid like lava can do in these patients. Many of us will go distal in those patients, and certainly in, let's say in women, you might sclerose some of those varices first, then create some kind of coil-based occlusion at the very lower or inferior end of the gonadal vein. And then many people will just try and fill space, right? They'll either use a sclerosant all the way up to the renal, maybe cap it with a plug, do things like that. Think about how easy it is to just take a solution like lava and just fill the space and go all the way up. And it can find its way into some of those branch vessels that we're trying to find with venograms as we're progressing in the embolization case. And so I think there's definitely utility for using this material in either varicoceles or pelvic venous disease, but it is both off-label and not really described right now. So I think you're flying a little bit on your own when it comes to work like that. But I can tell you it's going to be effective. It's just a matter of demonstrating and proving it.
Fair. So taking back to, we can use whatever dilated venous structure, but I was just thinking about in the setting of the tips, those sometimes are pretty juicy vessels, like greater than 5 millimeters. Only because, like we mentioned earlier, you said, oh, in the arterial system, you would stick to something maybe 5 or 6 millimeter range, top end of normal for using lava. But in the venous system, different rules.
The flow is different. So the flow is not quite as high flow, but it also, a lot of these circuitous connections as you go into a varix, they're really getting smaller before they hit the systemic circulation. And so in many cases, not all, but in some. And I think when you can appreciate that, then I think using the Lava 34 formulation is not going to make its way all the way through. And in some cases, I just did one fairly recently where there was a pretty clear channel into the azygos vein for one of these very large residual varices. I just went as far as I could in there and I coiled it first, and then I used lava to backfill it back down to the portal vein. And generally speaking, it was kind of a Freudian slip that used 5 ml there, but I think that's about right. So I have found that those large varices take about 5 to 10 ml of liquid to embolize them completely. So it is definitely a larger volume space. And it's just, again, you need to be aware of that before you jump into it.
This is the question that I had, in that people have been using liquid embolics in the neuro space for a long time. And then a lot of interventional radiologists have been using things off label for a very long time in the peripheral space. Why was it so long to bridge that need for just regular interventional docs who weren't in the neurointerventional space?
Well, it's probably a question that has a lot of different answers, right? So the first is to have industry support to fund the appropriate trials to gain peripheral approval for particular embolics. And so I think, Sirtex and Lava were very committed to getting that done. And I think that was a very important step for us as interventionalists. But when you use a product off label like that, you can't get the appropriate education to use it. And so, I meant what I said years ago. It was my neuroendovascular partner who taught me how to use it. I didn't have a company representative or someone who really was well schooled in learning the nuances of that product teach me like we learn everyday new products that we get. We have company reps come and show us the way we're supposed to use it, but we were never able to do that. So it was never really quite the widespread confidence for using liquids in the periphery. And I think that diminished people's appetite for that product. And so I think it was a lot of self-teaching. And I think that ultimately, as people became more comfortable using these products, there began to be more of a demand for them because once you use them, you just see. You know that it's a good addition to our toolbox. And now people want products that have been tested and that they can be appropriately educated on for use in the periphery. And I think that is the best part about having these newer products available to us, is that we can really learn the right way to use them and have conversations like this, that we can really start talking about how to do it, what our experiences are, and have people worry less about the potential implications of not learning how to do it the right way right from the beginning.